All right, we're live. So we're going to do the last few slides of this presentation. Then we'll get into analyzing the image, which is basically a sort of a big review of everything we did last year. So that'll be helpful, I think. But before we get to that, we have some new information. I love this image because it's all wrong. This is the wrong image for this slide. Anyone want to tell me why? Think about, so look at the slide title, spatial resolution, and then look at the image. Oman? Yeah, this would be good for contrast because it's the red apple that pops out and differentiates itself from all the others. When I did this, I didn't mean to do that. When I realized it, I decided to leave it in because it's a good discussion point to start off this portion of the lecture. So spatial resolution, if this apple were red, excuse me, it is red. If it was green and matched all the other ones, then we might be able to say that the spatial resolution is the ability to count all the apples, to see where the edges end and meet up with another apple. So part of spatial resolution is countability, right? It's the ability to distinguish one object that's in close proximity to another object, right? It's can be measured with line pairs per millimeter or line pairs per centimeter. But this is technically not a good image for contrast. It's for contrast, for spatial resolution, I should say. So the difference, though, would be if this red apple appeared green, then we would have very bad contrast, right? So contrast is the ability to distinguish objects that are in close proximity because they are represented by a different grayscale based on a slight or more difference in attenuation of the X-ray. Say that again. I have a mouthful, right? So contrast resolution is the ability to distinguish one tissue from another, especially if they're close together, close proximity, because they show up as a different grayscale, right? Different color, different shade. But that different shade is based on slightly different attenuation of the beam. In other words, it absorbs more or less radiation than the surrounding area. So you get a different grayscale. I usually talk about an analogy of kind of being on the beach. If you, today's not quite beach weather yet. I think the water's really cold. You might be able to walk on the beach, but don't go swimming. If you grab some sand, though, which you could do, and you're able to count the grains of sand and see where one begins and one ends, that's spatial resolution, right? If you're able to look at that sand and then say this grain is tan, this one's beige, this one's a little bit light brown, this is darker, this is lighter, etc. That's contrast resolution. It's tough to get the best of both worlds, right? Kind of tough to have to maximize spatial resolution and contrast resolution at the same time. Usually when one goes up, the other goes down, especially in CAT scan. And we get to talk CAT scan later this semester. Yay. I do a whole class on CAT scan. So when you finish X-ray school in whatever, a year and a half or so, right? A year? A little bit more than a year. A little bit more than a year. Then you can take my CAT scan class. Anyway, that's spatial resolution. And we said we can measure it in line pairs. We've done this in the lab multiple times. Our tool is nice and square and little, right? And it's kind of hard to sometimes see where the lines blur together, but where they blur, I know you guys have to come to a consensus because everyone sees things a little bit differently sometimes. But the consensus ends up being that where it blurs is where you've lost your spatial resolution. Another definition, so if we can go back in time for a second, another definition would be the ability to resolve small objects, right? The better spatial resolution you have, the smaller object you can see, right? There's actually a formula in CAT scan, so don't worry, it's not for today, where if I give the person the number of line pairs that the system can produce, they need to then tell me how small of an object can be resolved, which is important if you have a tiny, tiny, tiny tumor, right? You want to be able to literally see it. If you don't see it, what happens? It's a negative study, and patient goes undiagnosed. Maybe they get a nuclear medicine scan, which will allow them to see the object, but just not place it well. That's the problem with nuclear medicine, also known as molecular imaging. I teach in a nuclear medicine program. I'm doing an MRI class for them on Tuesday nights, so that's what I did last night, so that they can get into things like PET MRI, PET, which is a positron emission tomography. It's a nuclear medicine molecular imaging thing. So there's a lot of interesting things going on in the field that you guys can get involved in one day. Right. Strictly speaking, there's not as many jobs for nuclear medicine techs, so that's a little bit of a downside. Maybe that's why they're taking my course, so they can do other things within nuclear medicine. So we use this. We also use what's known as MTF. I'm not on this slide, I'm just yapping. Modulation transfer function, did we talk about that yet? MTF? All right, we'll save it, but we will. It's another way to put a numerical value on spatial resolution, but it also kind of covers contrast resolution a little bit. But sticking with our line pair test tool here, and this one happens to have been from a place in New York, so you can buy this there. Hey, Richard, how are you doing? Nice to join us. Yeah. So you can get away with that in Zoom, right? I'm not going to notice in Zoom. Easy to notice. Anyway, that's okay. Everyone's allowed to be absent a little bit once in a while, right? Life happens. I look for patterns, right, in clinic. Like if someone's late every day, that's not good. If someone's late once in a while, all right. My wife is trained well. She's late for everything. To the point I have to lie. Yeah, we're supposed to meet at 1. Like really, it's like almost 2 when we're supposed to meet. That way, when we're like 1:45, we're actually 15 minutes early. Sorry, she'll never listen to this. It's okay. My younger daughter probably knows more about CT than you guys do, because she listens to me talk about it all the time. Okay, so some math, right? The smallest object that can be resolved, in other words, seen, is known to be inversely proportional to 1/2, the spatial frequency that is given to you. So there's this formula. We're going to do an example. It's really not that tough, right? The minimum object size is going to be 1/2 or 0.5 times 1 over the spatial frequency. PEMDAS, if you remember your math rules about what goes first, second, and third, is we're going to do the stuff in the parentheses first. So in this case, you might get a question, and this is important. If you think about the reality, this is like whether you can see a tumor or not, right? What is the smallest object that can be resolved by an X-ray machine if you are given its spatial frequency in line pairs? This is very similar to what I was just talking about, of 3 line pairs per millimeter. So the 3 line pairs per millimeter is the spatial frequency. We go back here. That's this SF right here. All right. So it's not too hard, right? We go 1 times 1 is 1, 2 times 3 is 6. Do the division. And what is the answer? The smallest object that can be resolved is going to be, I mean, you could have left it as a sixth of a millimeter, but it's probably better to look at it in terms of decimals. So it was converted to 0.17. So that's almost 0.2 millimeters. That's pretty good, right? So most imaging systems, the size of the pixel is going to become a limiting factor. This is scary, right? This is saying that your machine, in quotes, can see the object, but because the pixels are not small enough, you can't see it on the monitor. You're being limited by the actual pixel size. The rest of this probably sounds like the following. You cannot visualize an object if it is smaller than your pixel size. Right? It has to be the same or bigger.
Oh.
So if you have a really cool CT, MRI system, but you like hook it up to your Holly Hobby, like, remember Holly Hobby? It was like the little toy oven, but I was going to turn it into the little toy television because none of you guys will understand anyway. Some of my weird analogies. Anyway, if you hook it up to like some terrible monitor that you bought for $100, it's not going to show up, right? So it's really important to have small pixels. The other limiting factor, which might be in this lecture, if it's not, it's in some other lecture. It all emerges in my brain. You can be limited by the focal spot size as well. So if the focal spot is not small enough, you're not going to see it. Were you just in the last class too? No? Yeah. Oh. Why am I mixing you up with someone? Just stay. All right. So no object smaller than a single pixel can be resolved, right? You would lose the spatial resolution. So is the object there? Yes, it's there, but you can't see it. So even if the machine can see it based on that particular machine's spatial frequency, if you don't have a large enough matrix where your pixels live, so matrix is rows and columns that crisscross each other and make little boxes. If those little boxes, which are the pixels, aren't small enough, then you can't see the object. Right. This is probably our first lecture of the year that starts to go digital. And we start talking more about pixels and voxels and matrix sizes and flat panel detectors and where the EI comes from and all sorts of fun digital stuff. Yes.
So did they happen post-processing after shoot the image that all this thing happens post-processing during the computer say images?
I mean, it's hard to, if your pixel size is smaller than the object, you're okay.
No, I'm saying this scenarios are taking place post-processing.
Yeah. So that's an issue. Again, potentially leading to a misdiagnosis. And that's not great because who wants to come back when you actually feel the lump? And then it's maybe big enough to visualize. So I think that's what's being said here, right? Spatial resolution is limited by the size of the pixel, which we just said. No object smaller than a single pixel can be resolved by computer-based systems. A detector element, right, which is part of the flat panel detector, and there's many, many thousands of them. So a detector element, sometimes known as a DEL or DEL, is about 0.1 square millimeter. That's pretty good. But even that, even if this is not a limiting factor, if the focal spot is more than 0.1, let's say 1.2, then even the spatial frequency of 0.1 is not going to help you because of the focal spot. Right. So there are systems that have smaller focal spots, generally in mammography, because you're looking for very small calcifications. There are some small focal spots being used in different types of IR, interventional radiology procedures, which is really, really fun. You haven't learned, I think you get that also from Professor DeVito in addition to physics. I think he basically does the IR course. So that's for angiographic things, right? Looking at different vessels, and that's a whole world. They make good money too, by the way. You get a rotation in IR, right? Like the first flip phone I saw that kind of opened up this way instead of this way was like some supervisor in IR. I was tempted to ask him, like, so how much money you make? Because this was a while ago, right? And they're still expensive now, but this was like, you know, a few years ago. Had this thing already. I was like, that's cool. The cool tablet, like half phone, half tablet. So yes.
So you're trying to say that if the focal spot is, like, say, 1, and then the del is 1, it'll be able, like, it'll be like.
So the example is, you can be limited by the size of the focal spot, or the size of the pixel, or both. So if the object is smaller than either the dimensions of the pixel or how big the focal spot is, you will not be able to visualize it, even if the spatial frequency of the system says that you can. So if the object is 0.9 millimeters, just short of 1 millimeter, and your focal spot is 1.2, and your pixel is 1, can you see the object? No, right? Because it's smaller than both of them. Let's say it's 1.1. Can you see it? No, because it might be bigger than the pixel, but the focal spot being at 1.2, still no good. Okay, so the other way that I alluded to was this MTF. What's the modulation transfer function all about? So this part we mentioned, right? It's a measure of an imaging system to give you contrast, and you can add spatial resolution into there. It's kind of like a general term, because actually the MTF comes from several different quality control tests that are done. Just to back up a little bit, you have this whole world that we haven't talked about called quality assurance, QA. You probably heard the term QA. Right? QA is a concept. Actual tests related to quality assurance are known as quality control, QC. So there's a difference between QA and QC. QC are the tests that you do. QA is a program that the hospital develops. Which tests are we going to do? What, you know, that kind of thing. Now, what we're going to see before we go over this is the scale of MTF goes from 0 to 1. And that doesn't sound good. I mean, what kind of scale? 0 to 1? But it actually goes by tenths of a point. So it goes 0, 0.1, 0.2, 0.3, 0.91. And the way it works is the higher on the MTF scale, right? The higher the number, the closer the image actually represents the object. So, for example, if you got a 0, that would be a black image. That would be 0% object information is transferred to image information. A 1 is unrealistic. A 1 would be 100% of the information related to the object is transferred to the image. That would be perfect. That would be like exploratory surgery, where we cut you open, take something out, and be able to look at it. X-rays are getting good, but they're not that good. A 0.6, 0.7, 0.8, that's much better, right? So a 1 really can't happen. A 0 can. That's just basically a malfunction, and you get a black image, and you get nothing. So that can certainly happen. Now, when it comes to this here, we have, as line pairs become smaller and closer together, like they are in A compared to B, see, they're getting closer. As wavelengths shorten, okay, what happens to frequency? We talked about this like in September. Okay, the frequency increases. Okay. We haven't quite talked about it, but there's a reconstruction, and it's similar in MRI, but now it's being applied to radiography, where we take wave and frequency information and turn those into grayscales to get our contrast. What you need to know now is the shorter the wavelength, the higher the frequency, that's going to bring out smaller details. And it's related to smaller objects. So small objects tend to be associated with higher frequencies. Larger objects tend to be associated with lower frequencies, longer wavelengths. So as line pairs become smaller, closer together, A to B, their rounded penumbral, we know that sounds bad, their rounded penumbral edges begin to overlap such that the exposure trace diagram that we'll talk about a little later, because we're kind of going in reverse, when they become close enough to see, we're getting into almost a microscopic scale, and we're going to lose our contrast at that point. Right. We're going to talk more about MTF. Okay, so this is kind of what I was saying. We can see smaller objects based on the wavelengths and the frequencies, wavelength getting smaller. So remember, the wavelength is the distance from one crest to the next one up here. And the more that pass by at a certain time, so if you're the observer and you're looking up and you're counting the waves as they pass you by, if you can count more waves in, let's say, 10 seconds, and you do it again and then count less waves, it's going to be the difference between a higher frequency and a lower frequency. Right? The more waves that you can count in the same amount of time, the higher the frequency. So we're saying that the modulation transfer function is related to the contrast and related to the object's actual contrast, right? It's trying to bring out what the object actually looks like. Not just shape and size, which is more spatial resolution, but also its own contrast compared to other objects. So yes, it's not in color per se, right? But I don't know if this is a great analogy, but at one point, everyone was watching black and white TVs, but you still had some TVs that were better than others, right? At a certain point, even though it was all grayscale. So if you had a 0.5 MTF, that would represent 50%. So sometimes thinking of it as a percentage helps. So a 0.5 right in the middle of that MTF scale would represent 50% of the object's true, honest, real information is transferred to the image. That could be better, right? So that's why 0.6, 7, and 8 a lot better than 0.5. Or if you had a 0.1, that's only 10% of object information being transferred to the image. Okay, let's take a look at this. So the resulting MTF values at the bottom, that's these, as resolution template line pairs becomes smaller and smaller. So this is our spatial resolution going from bad to better, right? More line pairs per millimeter. The exposure trace diagram in the middle, right? So that's this over here, shows graphically that you're losing contrast, which is also indicated on top here, right? Where you start to lose contrast. You could look at it on this illustration as well. And all these are directly from your book. So the MTF plotted against the spatial frequency that's here, right? In this case, it's line pairs per centimeter, going from little line pairs per centimeter and getting much more as we go to the left to right. B has both a higher MTF. So if we take a line and draw it, we could have drawn it over here or over here. I just kind of picked in the middle, right? We can say that this point here on B has a higher MTF than it is on A. And we can say that it also has a better spatial frequency because this slopes more to the right and A ends over here. Okay, so what is our trade-off? So this is the trade-off, right? So it's kind of hard, it's kind of difficult to maximize spatial resolution and contrast resolution simultaneously. I said that earlier, usually when one goes up, the other goes down. So to sum this up, for most imaging systems, there's this trade-off between sort of the contrast aspect of MTF and the spatial resolution, as shown here, where system B has higher spatial resolution, but lower MTF. So if we take this point here, it has higher spatial resolution in B, right? B extends all the way this way. But you can see curve A, which is this, if you follow it, has a higher MTF. Right. So very hard to get the greatest number of line pairs and simultaneously get the greatest or highest MTF level. Okay, so what we are going to do now is kind of revert back. So we're going to go up way to the top here, which is where our lecture first started. So the other group will watch that last part. Of course, you can watch it over and over too. They saw this, but you can also have the recording of this. I'm not going to stop recording. So this was kind of a review, right? So the vast majority of this was a review. We talked about spatial resolution and the differences between contrast versus regular spatial resolution like we just did at the beginning. So they did kind of get some of it. Then we went through this little exercise here. And we said when the MA increases, what happens to exposure? You guys tell me. Goes up, right? If we increase MA, it goes up proportionally, right? If we double the MA, we double the exposure. We double the intensity to the patient. Same thing happens with time, right? If we double the time, we double the exposure, right? And we know that when you combine the MA with the time, which is what we use most often when we're writing up a technique chart, instead of giving someone exactly what MA to use and exactly what time to use, we give the mass, right? And that allows people to play with the time, for instance, like bring the time down if you're worried about something like motion. Yet when you bring the time down and bring the MA up accordingly, you get the same exposure, right? Reciprocity law, does that ring a bell? So when mass goes up, just like MA in time, exposure is going to go up. Again, double the mass, double the exposure. Okay, we said KB affects exposure as well as intensity. and has a factor in contrast, and has a factor in differential absorption, and has a factor in the penetration of the beam. So KV does a lot of things, which is why I don't try to mess with it too much. However, when we increase KV, we know that a little bit goes a long way. We don't have to double the KV to double the intensity of the beam. We don't have to double the KV to get twice as many photons. We only have to go up 15%. Now, we don't always go up 15%, but let's say you went up half of that, right? 7% is still going to be a 50% increase. Not a 100% increase, but still going to be a pretty big increase. So what do you think this arrow is going to look like compared to the other arrows? This is a big fat one. If it works. There we go. Right. So I use, I don't use PowerPoint anymore. I use Google Slides, but I'm thinking of dabbling with Canva, maybe. My daughter uses it, and her presentations look good. She's in high school. It's got all sorts of things going on. What is it?
MIRO.
MIRO? Like Miro?
Right.
Like the artist?
It's for presentations. They come out very neat too.
Yeah,
I with it as well.
I don't know if I want to like relearn stuff though. I already switched from PowerPoint to this, but man, we'll see. I might give it a try. So generator, that's a hard question of whether it goes up or down. If you remember, it's based on what? We have different generators, and some generators are,
High frequency.
some are high frequency, which means those are the most efficient ones. At the opposite end, you have the single phase. But how does it affect exposure? This one's a little weird. Not weird, but when we say more efficient generator, what does that actually mean? Yeah, I know it's better, but what is that? What makes it better? Oh, so it's true, you don't need as much exposure time, right? But why is that? Okay, yes, it has something to do with ripple. By the way, when you have Professor DeVito, he's going to get way into generators.
Also, the photons will match the level of KV.
That's the key. So let me repeat what he said. When you have a more efficient generator, what it means is you increase the percentage of the energy attributed to each photon such that it's going to be closer to what you actually set at the console. So remember, you have a heterogeneous beam. So if you set 85 kV, you're going to get up to 85, right? But you're going to have a lot of 45s, a lot of low energy photons. When you go to a more efficient generator, you increase the percentage of photons that are actually at what you set. That's why you can lower the exposure if you go from a room that's single phase to a room that's high frequency. Because if you didn't, if you use the same exposure in a low phase room generator, and then use that same technique in a room with a more efficient generator, let's say triple phase or high frequency, you've overexposed the patient. And this is bad because the image gets fixed and it looks good, right? But you've overexposed the patient. And maybe that shows up in the DI. So the DI is a better EI. What I mean by that is the EI, exposure indicator that we've talked about a lot in our lab, has a certain range, but that range is different for manufacturers. The DI, which we talk about more in another class, was an attempt that worked to use a formula that will take 10 different manufacturers and all their different ranges and convert it to one DI range, deviation index, that everyone understands. So you don't have to walk around with something in your back pocket if you go from one job to a part-time job or whatever. We're all hustling up there. So you see this in clinic now. When you get those colors that come out, like it's yellow, or it's green, or it's red, right? There's also a number probably nearby, right? And there's a scale, it's like from -3 up to +3. 0 in the middle is like just right. If you go into the positive numbers, you've used too much exposure. If you've gone into the negative numbers, you've used opposite of that, not enough exposure. It's the not enough exposure that you worry about more because it shows up as graininess. When it shows up with the color red and it's like 2.1, then you know you've gotten an overexposure, but the image still looks good, and most texts just ignore it. They should do two things. One, be more wary, right, that they're using too much, or two, if it's a preset that just pops up, then maybe that preset is using too much, and they should talk about that at a I was about to say faculty meeting, at a one of the tech meetings. Like, has anyone noticed that whatever pops up that most techs use, and it's designed that way, it's supposed to give you preset numbers, but those numbers should work. Maybe it needs calibration or a number. Right? If that happens consistently, it's going to happen, you know, when it happens automatically, and that's legit. But if it's happening all the time, right? Or here's what's not supposed to happen. If you have presets that work, you shouldn't have to change the KV every time you do something. Right? If you see that the technologist is changing the KV by 5 or more KV, then what's the use of the KV preset that pops up to begin with? Right, so I don't quite know how we got on that tangent, but important to know. Okay, so filtration. What's it do to the beam? What's it do for the patient? Anyone? Short answer? Short answer test, explain filtration.
Unnecessary, that was unnecessary.
Okay, so from what I'm hearing, we're getting rid of some of the radiation. Or we're getting rid of the low energy, also known as longer wavelengths versus shorter wavelengths. These are the photons that would just not contribute to subject contrast. As I like to describe it, it's like these are the photons that like hit a hair on your belly, you know, and then don't do anything for the contrast in the image, right? But they add to the dose to the patient. So filtration is a good thing. What's the recommended filtration on our normal rooms that operate around 70 kV?
I think
No, it's the number you're never supposed to forget. 2.5, thank you. The last class, everyone said 2.5 simultaneously. I think the caffeine was really peaking in the last class. And you guys have kind of slowed down maybe just a little. Even people in my MRI classes that are out of X-ray school for like 10 years still remember 2.5. It's like hammered into them. So what does it do to the average energy of the beam when you add it? It increases it because it's kind of like, I've used this analogy before, it's like quizzes, right? If I take out like the 10 lowest grades, what happens to the average of the rest of the class goes up. So average beam energy goes up, what happens to the intensity of the beam? Intensity goes down because you literally have less photons. They get absorbed, right? They never even make it to the primary beam. They get killed in the tube before they even make it out. How about collimation? So if field size is increased, that means you're opening the collimation. Pretty simple, exposure is going to go up because you're exposing more skin, literally, right? Well, what else is collimation good for besides lowering the radiation by not exposing as much of the person? The other one. And yes. So it's good for contrast because it cuts down scatter. That's kind of like what happens first. Scatter is cut, and thus contrast goes up. Why is the scatter cut? It's about where the scatter is. Remember, there's more scatter divergent. Okay, we're going to talk about this in a minute, but I feel like talking about it now. It's my class. So KV increases scatter. Why? And think about pool tables, if you want to use that analogy. You know, what's the first thing after you drink a beer and you play pool? What's the first step in playing pool? That's right, you have to break apart. How do you do that? You get the white cue ball. If you just tap it and it like kind of goes like that, what happens to the rest of the balls? Hardly anything, if anything. That's low KV. When you increase the KV, you're giving much more energy in terms of KeV to the actual photon. Okay, bear with me here. Now, when you give more energy to the photon, when it hits an outer electron, that added energy will, one, even with low energy, but certainly with higher energy, knock out that electron. But sometimes if you don't have enough KV, you get a photoelectric effect and that photon dies and stays in the patient. But with more KV, you've lost some energy knocking out that electron. The photon changes its angle and can come out of the tube and out of the patient carrying the wrong information. That's scatter that shows up as noise. So that's how increases in KV increase scatter, because they increase literally the energy of photons.
However, do we still have more photon passing through the object, like instead of absorbing in terms of photon they just go to copy it.
So his question was, if essentially, so correct me if I'm wrong. Essentially, if you increase the KV, do you get more radiation coming out of the patient? Yes, the amount of radiation in what we call the remnant beam, which is really the primary beam, but we change names if it actually makes it out of the patient. So the radiation that comes out of the patient is called the remnant beam. If your KV goes up and you penetrate more, then you get more photons coming out. Our KV levels are still not high enough that we will lose 100% of the beam. Imagine if you had a 500 kV machine and blast through the patient completely, and you get no absorption. So what you get on your image is just black, right? So within reason, general increases in KV are good, but not that much. Because remember, this is what people forget. People think higher KV, more penetration, more radiation makes out of the patient, thus the patient gets less radiation. No, because think about what happens in the tube. When you have more KV, you're also creating more photons, right? Your intensity is going up. So so more might go through you, but you also created more to begin with. And with 15% more KV, you actually double the intensity before it even gets out of the tube. So your dose is going to go up more than it's going to go down because a few make it out that wouldn't have. Now, the systems that we use are happy with higher KV, right? And the only thing you can do to actually lower dose when you increase KV is it has to be associated with a decrease in mass. Because if all you do is keep the mass the same and increase your KV, dose goes up. Way up. So if you bring the mass down, remember what the 15% rule said. even though it was about KV, it talked about the KV going up by 15% and you having your mass, right, to kind of stay the same. If you don't have your mass, what do you think happens to the dose? It just goes up. So how about the part getting bigger? So this is also related to KV in a way, because when the part gets bigger, when you have a bigger patient, what do? You increase KV so you can penetrate. But have you noticed that even though you are trying to compensate for the thickness of the part or a bigger patient, the images still look pretty bad? That's because you increase KV, which in turn still increases scatter, and then adds noise to the image. So you never really get great images, right, on like 300-pound people. If they're 301, they look great though. It's just 300. I'm just checking. Okay, just want to make sure you're. And there are plenty of, unfortunately, plenty of 300-pound people out there, right? None of you youngsters. Yes.
I'm sorry, so what you said, just would maybe clear understanding, would there be more absorption in terms of photoelectric? The atoms are given out of more photons, and only absorption, you see, like, if you have an higher atomic number, it appears more whitish. So in this case of it will really change, if we have more absorption than the.
Oh, okay. I see what you said. So in terms of photoelectric, you would have less photoelectric effect, less of the photons getting stuck when your energy levels via KV go up. But ionization is just as bad whether an electron is barely knocked out or way knocked out, right? It's still an ionized atom, which is not good. Okay. So pathology is definitely an or, right? We had that long list at the end of last semester where you had to try to remember some of them. You know, my favorites are like ascites, which is a buildup of fluid. Obviously, you need to increase radiation, right? If you have some kind of mass or tumor and you know about it, it's on the requisition or something, you need to increase. If you have osteoporosis, you need to decrease because the calcium content is lower. And you know, you could probably say increase or decrease. In other words, the pathology is either known as what is it? Additive versus destructive. Yeah. You know, sometimes I even forget my own slides. Because there's a lot of stuff to know. I had all this stuff in my head in the first semester and couldn't talk about it. Right. Not to mention, I think I do more MRI and CAT scan than I do regular X-ray. Yeah, what did I teach last night? Oh, I taught MRI. Almost forgot. I taught MRI to nuclear medicine techs and radiation therapy techs who want to do other things with their lives. All right, so how about scatter, exposure? The question here is exposure to what? Well, luckily it says IR, okay? Because if the scatter hits the patient, then of course it's part of the dose. If the scatter makes it out of the patient, Compton scatter, hits the image receptor, then the image receptor gets more radiation, so the dose to the image receptor goes up. Not that we really care that much. Can't really make friends with your image receptor or talk to it. But in terms of the image, this is the part that matters, right? Image is everything. Right? If it were like X-ray Instagram, you would only show like the best images, right? And you could be like, that person does great X-ray. I want to be like that and influence everyone. The scatter, unfortunately, creates noise. So the way scatter looks on a digital image is a graininess, a noise. Back in film world, so you know, I'll get in my phone booth and go to a different place. Film, it showed up as kind of like a fog, right? So it looked a little bit differently, equally bad. But our systems now are very, very good at getting rid of scatter, right? So much so that the algorithms that we have on our own portable machine now do what's known as noise reduction, which some people might refer to that as like a virtual grid. But what it really is an algorithm, a mathematical set of instructions to reduce noise. Because we just said scatter really takes the appearance of noise. So if you reduce noise, you're reducing scatter. Either of those going down, whichever term you want to use, means contrast goes up. And if we can do that without a grid, then we'll save radiation dose to the patient because we're not worried about killing too many good photons, which is why when you use a grid, you have to increase your exposure. Now, it's just starting. So you guys, lucky you, pretty much every few years, something kind of is in the middle of changing. So every few years, each class, I can say something a little bit different. You guys are right now in the middle of sort of the mathematical noise reduction, where they're using it on some portables, but it hasn't spread to the regular department yet, right? There are still grids built into the tables, right? And built into the upright buckets. Eventually, they'll have better noise reduction techniques that will apply to all different parts rather than mostly chests, a few abdomens, and rarely some extremities like post-op. Portables, right? So right now, portables are limited. And they've come out with pretty good algorithms for those few procedures. When they come out with it for everything, then I suppose even the grids in the department machines will disappear. And that would be good, because then the techniques will go down all over the place, right? Because the techniques that we set are based, whether we remember it or not, that there are grids built into the tables, right? When you hit that preset for lumbar spine, it knows there's a grid there, and it's not using some kind of noise reduction technique. Maybe using a little bit of something in there, but not a full blown to the point where you get rid of the grid completely. So we're getting there, right? We're starting. It's the same way flat panel detectors started. You had one with a cord on it, so you really couldn't go anywhere, right? Rooms had two flat panel detectors, one built into the bucky that was upright and one built into the table. A lot of money at $80,000 or so a piece. Things got better. They put a big cord, pretty good solution, right? Just create like a phone cord, old style phone cord that is. And now you can take it from the table to the upright. And now, only fairly recently, have they come up with portable flat panel detectors. And that was like awesome, because for the longest time, you had to have a mixture of CR and DR. You needed CR cassettes to do portables. And you could use the flat panel detector, DR detectors, when you were in the actual radiography rooms. And that was bad because you had to have two different techniques in your head too. One, if you were using CR cassettes, which we will talk about. Unfortunately, it's going to be a little while before the next content specs come out, so we still have to talk about CR versus DR and the differences and all that. Even though we just got rid of it last year, right? We only just upgraded. A lot of places across the country are still using CR. Eventually, as that fades, it'll go away. The next thing that you'll probably see, besides better noise reduction techniques, will be flat panel detectors with different sizes. Right now, it's almost one size fits all. I have seen smaller 10x12s that are used pretty much exclusively for pediatric portables, like neonatal. But if you look at older CR and older film cassettes, there's a whole variety of sizes. You know, right now we've only gone down to basically one and sometimes 10x12s. Fine. So as the price goes down, then we'll see more of them. So when we use a grid, the exposure to the image receptor goes down, The exposure to the patient doesn't. Right, we need to compensate for how good the grids are. Anode heal, very little effect nowadays because we have this digital technology, but just in case it's on the registry, we know that, and this hasn't changed, it's just dealt with, that there's more intensity on the cathode side as it's diverging towards the cathode than towards the anode. So the idea is, especially if you have a long bone, because you get more the further away you get from the central regulator. So that said, you're supposed to put the thicker part of the anatomy towards the cathode side of the tube. And if you remember the slide, and I kind of can see the slide in my head, you had a picture of the femur, where the head of the femur, so the thicker part of the femur, proximal femur, was placed for one exposure by the cathode side and one exposure by the anode side. And the anode side that had less radiation because of anode heal effect didn't penetrate fully, right, compared to the cathode side. This basically is hard to even reproduce in the lab now because the digital technology is so good. So it's still happening, right? The tube, interestingly enough, the tubes haven't changed that much for years. CAT scan tubes are a little bit different, right? They're made for more heat. If you measure, so did you guys took protection? You guys know the difference between a sievert and a millisievert? Yeah, 1,000. So if you get a sievert, that's bad. If you get a sievert of radiation, that's, if a chest X-ray is 0.1 millisieverts, not even 0.1 sieverts, then how many chest X-rays will it take you to get one sievert? 10,000, right? Because you need 10 just to get up to 1 millisievert. So that's a, you know, that's a lot at one time. Yeah. So SID makes exposure go down. Why is the arrow big versus the other ones? Because it doesn't just go down, it goes way down. What formula is this based on? Inverse square law, right? Anyone remember exactly what the inverse square law is? Well, no. That's not, that may be true, but that's not exactly. You know, you gotta split out the whole thing, like that the radiation goes down with the square of the distance. Okay, so this is why when you increase your SID, you need to increase your exposure. Right? Literally, the way I always think about it is photons dying in the air. So I don't want to create a bidding war, but if you go to HSS as a senior, that's a pretty cool place. They have some cool fancy machines there, right? They have one machine called EOS, and it's for standing spines. And it has an X-ray tube going down this way and an X-ray tube going down this way, and they go down simultaneously. And you get an AP and lateral like at the same time. But in my brain, whenever I think about it, I always think of like the photons like crisscrossing each other somehow. Do any of them ever hit each other? Maybe, but I guess it doesn't matter. Do I recommend HSS? Sure, it's a good place. It's busy. I don't know, honestly, I don't know if I could work there. It's a little bit too busy because it's not just too busy, it's too busy plus high quality at the same time. So it's like not just quantity over quality. They want quantity and quality simultaneously, right? But it's a good place, right? They pay a lot. But most places now are trying, everyone's trying to match everyone. So overall salaries are just going up. That's good. If my older daughter's starving artist would have gone into X-ray school, she could be making a lot more money. Now, but some people don't like medicine at all. They're just, And you guys have seen things in the ER already, right? That are like not pleasant. Yeah, she said, yeah, like something definitely, like I have to talk to her later and be like, well, what did you see? Okay, so, OID. So when OID, this is similar to inverse square law. When OID goes up, exposure goes down the same way as the inverse square law. So if you double the OID, I don't know why you would want to do that because it would affect magnification, but anyway, if you were to double the OID, then you would cut the radiation down to 1/4. Right? So it's based on inverse square law. KV up, contrast down, that's my t-shirt. I'll wear that when it gets warmer, even warmer than today. When KV goes up, why does contrast go down? It goes down because of scatter, right? Goes down because of scatter. Now, sometimes you have to use more KV to penetrate the part, right? That's again, basically why when you have a large person and you try to compensate that with more KV, images still don't look great.
And the reason why you use grid.
Yes, and a reason why you would use a grid, which still only does so much, but it's better than not using a grid. So generator, we talked about. Kind of similar to KV in a way, like when you go to a more efficient generator, you typically don't need as much KV, right? Which will also cut the dose. Field size, this is the same thing as collimation. So if the field size opens, then you get more scatter, right? Remember, you're getting more scatter at the periphery. So if you cut that down, right, then your contrast will increase. But if you open the field size, not only are you exposing more radiation to the patient, but the image is going to look worse, right? Contrast is going to go down. Same concept here, right? So we can kind of skip this one. Pathology, as we said, can go up or down. Scatter up, contrast down. I guess I like that one. Use a grid, contrast goes up. I could add the dose arrow would also go up, right? Unless we get rid of the grids and like we were saying, the mathematical noise reduction algorithms really kick in a big way, and then we don't need to use a grid at all. Then we would not have to worry about grid lines. We would not have to worry about anything heavy. We would not have to slip on anything. And if you played with that thing, it's like a big pain, isn't it? It takes like 2 people to put the grid on in the lab. It's not optimal, right? So life would be better. Of course, the number one thing, if you were to write an essay, the number one thing would be patient dose goes down. The last thing would be like easier for the tech and lighter. That would be like low on the totem pole. Still good, but not directly related. OID, we said if you increase OID, that scatter, instead of hitting the image receptor, has a chance to diverge and miss the image receptor. And thus the misinformation or disinformation, that's how I think about it. I think of each photon carrying like a little bit of information, right? And if it's traveled kind of weirdly because it was knocked to begin with and it changes the angle, that's the whole idea of scatter, then it's going to affect your contrast. But if the OID increases, some of that diverging scatter diverges right off the image receptor. And does, in that case, who would that be bad for? It wouldn't be bad for the patient. Well, it's still bad for the patient because it still resulted in ionizing an atom, right? That's not good. It's not bad for the image receptor because it misses the image receptor. Who's it bad for? Us. That's occupational dose. when it happens. So wear your aprons and stay away. Speaking of the tests that we had the other day in the lab, for not all of you, but for some of you. The biggest things I saw were not so much the images. When it comes to the images, there were some alignment issues, I think, particularly with KUB. I was getting some of the images look more like a pelvis than a full KUB. I don't know if it was like self-collimating because you didn't put portrait versus landscape. Maybe that could have been some of it. But the biggest issue I saw a lot was the breathing instructions. So, and I think part of that was because students ran away when they realized the other student was about to take the image, whether they said X-ray or not. So I think that may have affected the person taking the X-ray such that they didn't say X-ray. They just went right into the breathing instructions. So I saw a little bit of that. I also saw kind of like a mix-up a few times. So it's supposed to be X-ray, then you do your breathing instructions, then you say breathe, then you say clear. I saw a lot of clears, and then I'm still waiting for them to tell the patient to breathe. So what I think you do in real life is when you say X-ray, not just that you're supposed to take all day long, but you say X-ray, and that's then everyone leaves and you kind of take your time and do what you need to do. You don't rush through it. Right. Don't take all day because people have to do stuff. Right. But that's your signal. And I don't, not that we got behind in the lab in terms of time. So in a way, I'm glad it kind of happens somewhat this way. But in reality, you had a lot of time, right, to say X-ray and then kind of, and then figure out what you have to do. Right. So otherwise, most images were marked. Most images were with EI. Very little anatomy was cut. I could have seen some more collimation on a lot of things, but not to the point where I would repeat the exam. There were a few where there was actually too much collimation, and that actually cut, which is unfortunate because in reality, you were trying to save radiation, but now someone has to go do a repeat and just add more radiation to the patient. So that kind of defeats the whole purpose. But otherwise, it went pretty good. Give me about 8 months to put the grades together, and I'll get it. No, I managed to at least write notes on just about all of them, so it won't take too long. I'll get it before the semester ends. Oh yeah, don't forget we have a test next week, right? Quiz. Yes, yes. Here in here. Bring your devices. I got rid of the lockdown browser, so we don't have to worry about that. I allowed backtracking, so you can do all that. I think it's even better than backtracking because I think all the questions come up at the same time.
Oh, that's even better.
So that should be good. We should be good. So I've done all that stuff. Try not to have technical issues. But if you do, I think it lets you in one more time without having to contact.
I mean, bring one piece of tracking.
Sure, you can even bring 2 of you. But they have to be blank. So they're not like notes scrap paper, right? They're like blank paper. Just to be clear, have to be clear. People tell you that you weren't clear. So motion, and what's this thing about false images? So real quick, because we're starting around out of time. We want to control motion. So the best way to do that is to lower your exposure time. But also speak with your patient if you can, right? If it's a situation that you can. In CAT scan and MRI, we do gated exams. We don't do that in general radiography. So we're not hooking anyone up to an EKG. We're not doing cardiac imaging. I don't think a chest X-ray counts as cardiac imaging. I guess technically it would, but it's not like we're worried about the heart beating. But in a CT and an MRI, you can't slow down or stop your heart very easily unless you give drugs, and that's not good either, right? So all we can do is either time the exam so that we're extracting data during the same cycle of the heart. So let's say ventricular stole, and we grab some data. So you hook up an EKG and you say, at this point on the EKG, you take data. All right, slows things down because you have to wait. But you're doing, even if the heart is beating, at least you're trying to get data at the same time each cycle. So we don't have that in radar. What we do have is what we call false images. So the best way to describe this is, you guys have used tracing paper before? So imagine you're tracing something, and then you take another piece of tracing paper and you move it ever so slightly and trace it again. And then do the same thing and trace it again and again and again. Now you take your 5 or 6 sheets of tracing paper and line them all up. It's going to be blurred, right? Because every line is going to be slightly off. That's what you get in an X-ray. So when we have motion, it looks like a blur, but what it really is a lot of images on sort of on top of each other, but not lining up correctly. That's what they call false images. Okay. And of course, when motion is increased and not compensated for, I would probably argue that not only contrast goes down, but certainly spatial resolution also. So the rest of these few slides look like this. I'm going to not go through them. I'm just going to flip through them so they end up getting recorded, right? But we've talked about all this already. It's basically going over everything we just did. Of course, you'll be able to pause when you look at this. What we didn't do, which you can catch on the next video, because I did do this in the first class, was a little bit about geometric penumbra. And essentially, you can watch the video, but we said spherical objects create more blur, more penumbra, because the beam doesn't line up with the edges of the object, right? So in this case, there's not that much penumbra, and your book, so other books don't do this. Your book kind of says that the penumbra goes up the more shallow this slope of this line is. So let me just jump ahead a little bit. So if you look at this in terms of slope, this is very shallow. Thus, there's a lot of penumbra, which makes sense because it's a spherical object. The radiation beam only lines up with like maybe 1 point of the object. Look at A. It doesn't get any better than A. The beam, the divergence of the beam is so lined up, it actually superimposes this line that actually represents the object. So it has as steep of a slope as you can get, which is basically straight up, right? You wouldn't want to walk up that hill, right? The one in the middle, still pretty steep, right? So you're getting a good amount of blur, a good amount of penumbra, not as much as the spherical object, but definitely more than, I don't know, what is that? Trapezoid or something? I forget my geometry. But it lines up, right? Okay. We'll leave it there because this is where we started, right? I'll put up both videos. Just make sure you watch whatever you didn't see here. Yes. With Professor, with me? I did my lab quizzes already. Really? I'll have to take a look. Give me one.